Thank you. Thank you, Vikas, for having me here for SnoreCon. Thank you, Sipla, for organizing the logistics to get all of us here together. Good morning, dear chairpersons. Good morning, all friends here and offline. At the outset, I have my disclosures in strict accordance with NMC guidelines. Today, I have a very simple yet daunting task of trying to tell you about history taking, which is like one of the simplest things. But sometimes it gives us so much more information that if you ask them the right questions, you'll probably know a lot of things that you can do with regards to how you want to progress further. I'm going to restrict my talk to history taking, clinical examination, and a few of the things that would be probably part of your first consultation with the patient. And that's something that you've got to do in the 20-25 minutes that you have. So the first 5 minutes generally go in listening to the patient. You've got to listen to them. You can't just go on, sorry. You can't just go on asking your questions. So the listening takes about 5-6 minutes. You've got to be a patient listener. Then you pick up a few things while you're listening, while you're talking. And that's how you take it forward as to how you're going to formulate what you're going to do next. We definitely strongly recommend FNLP as a part of your examination. It's not something that you do it separately. It's like when you do an otoscopy, it's part of your clinical examination. FNLP for sleep is exactly that. Bring you greetings from Pune. It's the Oxford of the East. And we do understand there's a huge underdiagnosis here because the incidence is very, very high. You can imagine it's to the rate of 19-20%, which is very high. And then the patients are going to present to you, not directly, at least now they do, but generally you will have to maintain a very high level of suspicion and you will have to ask those leading questions. But as you start a niche sleep practice like some of us do, you're going to get patients who are going to give you all kinds of symptoms. They're going to come and talk about insomnia. They're going to talk about sleepwalking. They're going to stop talking about bedwetting. So you have to first figure out and differentiate these. You don't want to be dealing into parasomnias, dysomnias. We are looking mainly towards OSA. And when we look at OSA, this is what we are actually going to be looking at and asking them. You've got to look at symptoms of gasping, choking episodes. You've got to look at symptoms of snoring, early morning headaches, and the very characteristic giveaway is the not feeling fresh in the morning, along with, of course, daytime somnolence. But the not feeling fresh in the morning is a very straightforward giveaway of underlying sleep apnea. But now the question again about snoring is this. Are you going to be actually evaluating all the snorers who are post drinks in the night? Are you going to have those who are occasional snorers or the habitual snorers and the heroic snorers? And the answer is very simple. We are looking at only the habitual, heroic, or any snorer with quality of life issues or with daytime somnolence. We're not looking at the occasional snorers. There are plenty, dime a dozen. We're not looking at the ones after alcohol. We do understand that. But you have to look at all of these very specifically. And when we look at them, what are we actually trying to elicit from the history and all this examination? We're trying to differentiate what is simple snoring and snoring with sleep apnea, because the treatment would be totally different. A simple snorer is like somebody given to you on a golden platter. This is the right person for you to treat, fantastic success rates. The one with sleep apnea, we've got to differentiate whether he's going to be an obstructive one or a central apnea one. And again, out of these, whether it's snoring or whether it's the sleep apneic, you are trying to locate where is or are the obstructions in this particular patient. So that being our aim, we also in that same history and examination have to try and understand a few questions in your own mind. Are we looking at skeletal or soft tissue obstructions, or are we looking at them both? Is it a single or is it a multi-level obstruction? Is it likely to be surgical or non-surgical? Can you get away with very simple office procedures, or will we require something very complex? Now, understand that in those 5 to 10 minutes and 15 minutes, these questions must race through your mind because you've got to give answers to the patient after your first consult. So, some rough ideas. And therefore, all your important history taking, will be directed to everything to do with quality of life quotient issues. So everything that the patient has a difficulty with quality of life, you've got to try and elicit that. but also understand a few other points. How has that patient reached your clinic? When I say this, I don't mean how by car or truck or whatever. I'm talking about, has his wife brought him? Has his spouse brought him? Or has he come on his own? Because that will give you a very, very strong indication of his motivation and whether he's going to continue forward with treatment or not, or is he just a casual consult that has come across to you. You also need to understand whether he understands the disorder and a rough idea of his background. That doesn't mean I'm asking him what is his annual income and I'm asking him to put it down on a paper. I'm trying to understand from his background whether a farmer coming to me is not going to give that much importance to his snoring vis-a-vis a person who's in the corporate world, who's going to definitely give a lot of importance to his problem. So the socioeconomic status along with the profession of the patient, because again, like I said, if it is affecting his profession, if he's an employer, he'll have a different attitude. If he's an employee, he'll have a different attitude. So the employer is a boss. He will have his own way of dealing with problems. He's the boss of the company, he's whatever. So that is important, because if he's an employee, his work performance is getting affected, and this is important for him. Otherwise, he's going to get sacked. He's going to lose his job. You also have to try and get an idea without intruding into anybody's private life as to any kind of situations that are happening in their marital background. So that's something you have to elicit, or rather the spouse herself will tell you. And without exaggeration, 80% of couples with these kind of problems are already those who can afford to sleep in separate rooms are sleeping in separate rooms in today's date. So this will also give you kind of an idea. The other thing you would want to know is, where are they coming from? A person coming to you from within the city is very different in the management protocols that you will follow from somebody who's coming from outside the city. It'll also be very different from a person who is outside city, where you need to get investigations done at a faster rate as compared to somebody within the city. You also have to try to identify over here, when you generally start a niche practice, you will get people coming to you from different parts of the country, different parts of the cities. You have to try and understand whether has this person really come to you just because he's heard your name and he wants to put it on the bucket list. कोल्हापूर मधनं मी जाऊन मुंबईला पुण्याला यांना भेटून पण आलोय, पण तरी काय झालं नाही. Because these people are difficult ones who will create the reputation for sleep apnea treatment. So you've got to try to judge this within your history taking in those first 15-20 minutes. If he's just come here to tick the box that I went and saw Dr. Seemab Shaikh also, then that's not the kind of patient that you would want to be very happy about. But the presence of comorbidities, obviously you will need to ask diabetes, asthma, blood pressure, because these will affect your treatment protocols in the future. This changes in pediatrics, because this is not the same history that you're going to elicit from the pediatric patient. You're going to look at hyperactivity, you're going to look at mouth breathing, snoring. Bruxism becomes very common in children. Bedwetting is a very big issue, but the most important aspect I give importance to is the scholastic performance. And that does not mean we're talking about last unit test to this unit test, his marks have decreased. No, you look at the scholastic performance over a period of about 6 months to a year. And if there's a gradual decrease, then that is worrisome and that requires faster and earlier intervention. So when we talk about examination part, besides the history taking, this is all the armamentarium that we have, out of which cephalometry is nowadays redundant. We don't do it. Sleep nasal endoscopies in India are not available. So we stick to whether the clinical evaluation, the FNLPs, and the dynamic MRIs or DICE, as we normally talk about. In a clinical examination, it's right from the beginning what you assess with the way that patient walks in with his body language that tells you whether he's already in some stages of endogenous depression, motivation issues, he's just fed up and he's just here for just another consult. These are things that you need to pick up when you're dealing with the patient as they enter in. You read a lot about collar size and this and that. I have till date not measured collar sizes. I've never asked them for collar sizes. It's all for academic things to write down. But you are overall judging the obesity issues anyways. And that patient walks in, you're looking for central obesity, you're looking for neck adiposity, you're looking for any other thing overall that you find is going to affect your treatment protocols. And then when you actually get him to stop talking and take him to the examination place, this is not for me to tell you about how you look into the nose and how you will obviously see a structured deformity there. About the oropharynx, you'll see large tonsils, maybe an uvula. Rahul has already spoken about Dr. Friedman's paper in this, which is a very characteristic one. You can all read about it. But the basic thing, what we are looking at is the tongue position and the size of the tonsil, which will give you a rough idea. So clinically in those 10-15 minutes, again, if you're looking at a bigger size of a tongue, if you're looking at larger tonsils, you're getting a rough idea which and what position of Friedman you're trying to put them in. And based on that, obviously the surgical outcome for palatal surgeries would differ. It won't really tell you much about the surgical outcomes for your other surgeries, but at least you have a better idea that if I'm dealing with a huge base tongue or a huge tongue, in fact, because like Vikas says, you don't see the base tongue from the outside, you will not be able to do very good surgeries for the palate in such patients. So that's what probably Friedman just tells us about. And in the scopic evaluation, so you've done with your history taking, you've done with some judging, you've done with some clinical examination. And then when you go to the evaluation with the scopes, we are only going to do either the FNLP, which like I said, is part of the regular clinical examination, or that you do a DICE or a dynamic MRI. We will discuss across the day. But what's important to see here is you are going to have to look at not just the AP collapses that we are normally training our eyes to look at, but you will be looking more towards the mediolateral collapses also, because that's how the patterns are changing now, and you need to be able to judge this in your typical evaluation. So you might just see something like a huge tonsil there, which is blocking that entire airway, but down below, everything looks nice and open below the tonsils. I'm unable to forward it from here because of the, just give me 10 seconds and everything below that is quite clear. So let's not, or you might have something like a completely collapsed epiglottis that even Rodolfo was showing you, and that could then give you trouble for usage of CPAP. So let's not get there. Then we went into advanced DICE to be discussed later. But then in short, what is the protocol that you would follow? So you will follow the typical history taking and try to evaluate in those first 7 to 8 minutes of that. Then there is 2 to 3, 5 minutes of your examination part. And then after that is the next 5 to 7 minutes or 10 minutes where you really have to sit down and explain everything to the patient and the relative if they're there. So you've done a history taking, you do a clinical grading, which gives you a rough idea, reasonably rough idea, not a complete idea. And you do an FNLP where it is. And on that day one itself, in your first consult, the patient leaves by filling out an ESS form or any stop bank questionnaire that you prefer to use in your OPD. You schedule the sleep study at that same day or that same night along with the CPAP trial. And if there are associated conditions of allergic rhinitis and things like that, you make sure you treat that before you get into the evaluation part. And in that first day consult itself, you've got to keep it in mind, because by now in those 10 to 12 minutes already while talking to the patient, you have an idea of what he actually expects from you. What is he here for? And if his expectations are not exactly what we are supposed to be talking about in sleep apnea, then you've got to make those changes. You also have to judge in that what is the patient's comfort level, what are his choices. There are some who will come and tell you point blank, I don't want any kind of surgery, what else can you do for me? There are some who will come and tell you, I'm using CPAP but I'm fed up with CPAP, what can you do for me? So you've got to understand their choices and keep your own self training and expertise in mind. And in a previously operated patient that comes to you, it's very important to take this kind of a history. What were his issues then when he's come to you? What are they now? Was a sleep study done that time? If it was a level 3 done, then this time you might want to go for a level 1. You need to know that. Was a DICE or an FNLP plus Cine MRI done at that time? And what were the findings? He should have them with you so that you can compare it with what you have now. Was a CPAP trial done that time or not? If at all any procedures were performed, what were the procedures performed? Were they performed single stage? Were they performed multi-stages? And what were the results, outcomes of that? Were they checked with a repeat PSG or not? These are important histories in an operated patient. Were there any intra or post-op issues at that time? and what are his present expectations. Because when you have to evaluate these patients very properly when they are operated in a UP or any palatal procedures early, and you'll probably find a lot of things as you see below, that the patient has been operated for a palatal procedure, but they probably missed out on quite a few things along the way. And that's what you've got to locate. So you will see over here as you go down that the apicalops still persists. There is a little bit of salpingopharyngeal folds that are coming in. And as you go down, you will see a very huge tongue base, which probably was missed for whatever reasons, and a collapse of the epiglottis that was missed at that time. So that is why in an operated patient, it becomes very important. This is even pre-DICE. This is just in an FNLP. This is your part of your routine evaluation. So the other few topics you may need to touch on, I won't go into detail, is how you kind of give them what is success of treatment, because they will ask you. So you've got to give them a rough idea about downgrading your problem, improvement in quality of life. Don't talk with terms of cure and things like that. You may have to give them an idea, like what Rodolfo said, that there's CPAP versus surgery. There is surgery of two types. There's surgery for CPAP optimization, and then there's actually surgery for surgery versus CPAP. Figures are there for you. It's there in literature. There are things that you will have to talk to them without rubbishing away CPAP. Because we do right now acknowledge that probably for lack of better evidence and lack of better words, CPAP is the gold standard. But you will have to give them an idea that CPAP is not the final answer, as was once thought earlier. There's lots that we can do, although surgery is also not the final answer. And in a broad perspective, these are the kind of patients that you will select from that history taking and this about taking up for surgery. This is a very broad surgical candidacy, where we as ENT surgeons will not give too much importance to the AHI. We will talk about that through the day. We will not give that. We will be looking at the anatomical obstructions and try to get rid of those. Like I told you in the beginning, primary snorers will be given to us on a golden platter. And anybody who's had a failure of CPAP compliance obviously is somebody that we need to look into. And BMI, we try to keep below 30 as much as possible. So do understand that surgeries are not technically demanding, but it is the application of the mind and the selection of that cases, and that starts from your very first history taking and clinical examination as to which ones you will take forward. Thank you very much.
Dr. Seemab.
Sir, sorry.
Thank you so much.
Thank you, sir.
That was extraordinary, I must say. But what is the heroic snorer? What do you mean by that?
So heroic snorer generally is defined as a person whose snoring can be heard behind a closed room.
I see.
So outside the room with closed doors, if you are able to still hear his snoring, that's termed as a heroic snoring.
Okay.
And there is no dearth of heroic snorers, let me tell you that. There is no dearth.
What is the full form of FNLP?
Flexible nasolaryngopharyngoscopy.
Okay.
Sorry,
you kept mentioning that right in the beginning.
I shouldn't be putting, but it's a snore con. So
I have to thank Dr. Parikh, my co-moderator. Of course, Vikas, the pioneer.
Absolutely.
In snoring and sleep surgery.
Absolutely. Because of whom we are all here today.
He's done most cases in India, that's what I'm sure. Thank Orient and Cipla. And one more thing I have noticed, to become a sleep apnea surgeon and to become a surgeon for snoring, you have to be young, handsome and dynamic. Like all the three speakers, including Rudolfo.
Thank you, sir. Thank you for the compliments.